Good evening. I am Dr. Anil Parikh, President Medical Affairs and Clinical Research at IPCA Labs. It's a great pleasure and privilege for me to welcome our esteemed faculty for this seminar, COVID-19 with comorbidities, namely hypertension, diabetes, and coronary artery disease. I think I welcome all the participants and all the doctors across India who have joined today. So today, I think I consider myself fortunate because I'm interacting with a good faculty, uh, which is led by the session will be moderated by Professor Sudhir Bhandari. I have been fortunate to interact with him when we were working on hydroxychloroquine in type 2 diabetes, the first anti-inflammatory drug. He has been the one who has been involved with this development along with us. So for last 1 decade, I have been interacting with him, and he is currently the principal and controller of SMS Medical College, which is the largest medical college in India. And also he is uh, the senior professor of medicine and consultant physician in internal medicine, diabetes, endocrinology at SMS Hospital. And now I think he has been also associated with his honorary physician to His Excellency the Governor of Rajasthan, and in fact, since last 2 decades, I think he is looking after as a personal physician to all the governors of Rajasthan for last 2 decades. So that's his introduction, and why it is important why I consider him important is that he is, I think, personally treating so many patients. I think the very rich experience of dealing with the live COVID-19 patients. So his experience is going to be very important that most of us can learn from him, how to manage these patients and what are the various types of patients. And SMS was the earliest to, devise a treatment for COVID-19. And then subsequently the, other uh, isolation and other things. I think all this contact tracing and all these things were done under his direction at Bhilwara when the cases erupted. So we are really fortunate. And next, I would like to introduce Dr. A.K. Pancholia. I think he is HOD Medicine, Clinical and Preventive Cardiology at Arihant Hospital, Indore. I have been fortunate to interact with him for last many years because of my work on chlorthalidone when we conceived the 6.25 milligram dose and combinations with chlorthalidone. So he was instrumental in advising us. So I think it will be great to listen to the wisdom of Dr. Pancholia, who is also very much involved in preventive care of preventive cardiology as well as clinical cardiology. Next, I would like to introduce Dr. Raghav Sharma, who is a consultant cardiologist, and he is involved at Ambala Ambala Hospital and has got a lot of interventional procedures he is currently doing at Ambala. Then I would like to introduce Dr. Mukul Kumar, who is Head of Department of Cardiology at Dr. Rajendra Prasad Government Medical College at Kangra, Himachal Pradesh. So we will have a good wisdom from them about the cardiological aspects of COVID disease, where COVID itself is having myocarditis and other complications. So how important it is to manage these patients of COVID. So that input we can have from the two cardiologists in our panel. So now, without any further ado, I would request Professor Sudhir Bhandari to kindly moderate the entire session from now onwards. Professor Sudhir, please.
Yeah, thank you very much, Dr. Pari. First of all, I extend my profuse thanks to you for organizing such a wonderful interactive session. I profusely welcome Dr. A.K. Pancholi, who has been a very reverend faculty, Dr. Mukul and Dr. Raghavan. Welcome to our webinar. To begin with, all of us are facing a very interesting challenge which we had no experience. I would just quickly tell you, we belong to SMS Medical College and attached hospital, which is one of the country's biggest medical college hospital. Our bed strength is 6,000 bed with 38 specialties. And the profile of hospital, you can make out that we had 2 heart transplant, regular liver transplant and kidney transplant. So every possible SMS hospital was turned into the first state COVID hospital. and we dedicated 250 bedded ICU and 1,000 beds to COVID. I must share with you right today also, we have 558 COVID patients admitted with us, with 22 in ICU and 15 in semi-ICU, rest in the various positions. Now, it has been a very interesting experience from day one that how are they presenting, what are their symptomatologies, how many are symptomatic or how many are asymptomatic, and what are multiplication of their symptoms, what are cardiac issues, the GI issues, the diabetic issues, etc. So today we'll be very happy to have your input on hypertension, diabetes, as well as cardiac problem associated with this COVID patient. I will just share with you that we have a unique experience at SMS. You'll be surprised. So far, we had 26 deaths. None of the deaths, COVID deaths, has been exclusively because of COVID-related pneumonia. All had comorbid condition, and classical comorbid conditions were diabetes, high blood pressure, as well as ischemic heart disease. In fact, two of our patients had acute MI while being admitted with COVID pneumonia in ICU. That will leave a plethora of discussion between my cardiologist panelists who are there. At the same time, we had almost 60 to 70% patients who are asymptomatic. And so if I give you the statistics of COVID, I'm sure all of you know by now that if you take the overall presentation, 80 to 81% are asymptomatic. They don't have any significant disease. 15% or so, they have mild to moderate disease, which can be managed. And 2 to 3% people, especially those who are having comorbid conditions like high blood pressure, heart problem, cardiomyopathy, diabetes, or immunocompromised people on cancer or steroids, they develop pulmonary disease, and where the point of reversion becomes very difficult. Now, we were very lucky. Among the first few patients, we used many times the drugs first time. Now, I must share with you, corona or the COVID-19 infection, so far, it's very new. Though we had a lot of experience of reading and knowing about SARS and MERS. All of you must have read about it, that this is a kind of a viral infection which predominantly affects the lung. When first three patients we got at SMS Jaipur, there were three Italian tourists who, one of them was a doctor who was 70-year-old with the underlying COPD. When they reported first time to SMS, we were all prepared and geared. Now, along with the supportive medical treatment, the other supportive treatment, we had a challenge. What do we do to reduce viral load or to reduce viremia? We checked up all the literature available. We checked up the literature available for SARS, MERS, as well as what we can use a common drug which has some antiviral effect. We learned some French trials and we came to know that hydroxychloroquine is a one drug, although we'll be talking and debating a lot about it. But with our immense experience of using hydroxychloroquine in rheumatoid, in SLE, and later in the diabetics also, average Indian has tons of experience of using chloroquine and hydroxychloroquine. So these were the first three patients. So far in Rajasthan, we have 10,000 plus positive patients, 1,700 plus in Jaipur. We use hydroxychloroquine. We monitored them closely. First patient was 70 years old. Second patient was 85-year-old. We were very skeptical in that because of the cardiac issue, but he didn't have any cardiac problem. And third was 54-year-old. And then we coupled up with antiviral drug lopinavir as well as ritonavir. To utter surprise, we were having known about this. We were very confident of using this. We were closely monitoring, which we never did in rheumatoid or the SLE patient. Morning, evening, their ECG, we were monitoring the QT interval. We were looking for the, if any 25% above rise or not, we were looking for the scoring for the thing. And fortunately, all the three patients whom we used this drug, they recovered. So there are a lot of questions which is being raised subsequently by the rest of the world, by our own fraternity, which I'll be posing to you. I must share with you that this was a one drug we felt very confident that whenever you start using a drug, you need to look for the benefit and side effect ratio. If you have read about the cumulative toxicity of hydroxychloroquine, it comes after you use the 1 kg of it. So tremendous tilt in favor of benefit with a side effect. It was prudent to use it. Secondly, a definite pathophysiological advantage mentioned by reducing the viral load, reducing the changing the pH intracellular, reduce. There's so many advantages: the immunomodulator, the antiplatelet effect, and secondly, at a stage when we didn't have too many specific drug like oseltamivir for H1N1, we didn't have any specific drug at that time. So it is prudent to use the drugs which are available, seen in literature with some good effect in vitro as well as vivo. So worth trying drugs to begin with and following the longer trial. And similarly, we use some antiviral drugs which has some or other pros and cons and some other positive or negative interpretation subsequent trial. But if I put it that way, of our now as on today, we have almost 100 plus patients. Before I came to this webinar, I checked up 114 patients who are mildly symptomatic, who are on hydroxychloroquine out of our 558 patients. None have any QT issues, none have any tolerance issues, and they are fine. We are also doing a study that how fast a patient without hydroxychloroquine becomes COVID negative and patient with hydroxychloroquine becomes patient negative. So without and with, we'll be coming out with a lot of interpretation, but bottom line is that whatever may be the long-term effects and interpretation, the ratio of benefit versus side effect goes all in benefit very closely monitored. Secondly, we have been coming across the cardiac complications. The diabetic patient has fluctuations. We have been having a lot of other issues, etc. So I welcome my panelists. All of you are now well aware of the do's and don'ts, COVID, etc., which I'll not be talking about you. So I'll start with our colleague, Dr. Pancholi, who has been a master cardiologist, who has been very eminent and got a lot of laurels in preventive cardiology. I would like Dr. Pancholo to speak about that. How does he see the issues of hypertension in COVID-19 patient and what has been his experience in last 1.5 months?
As per the reports from other countries and from our country, this associated comorbidity are commonly seen in patients with COVID, the severity of the COVID-19. As Dr. You are already pointed out that the common comorbidity are hypertension, diabetes, cardiovascular disease, chronic kidney disease, cancer, and others. But we found that the commonest comorbidity found in all the reports is hypertension, which was reported to be 30% in the initial reports from China. Subsequent reports showed 27.5%, and the recent report on 10th of April, they showed the patient who died, they found hypertension in 50% of the patients. So it is unclear whether controlled hypertension has mild disease. It is unclear, but it is very clear that those who have uncontrolled hypertension and associated target organ damage, they have a more severity of the disease.
Okay, very good. I think that's what you said is very correct. Now, Dr. Mukul, I have a question to you. That suppose any COVID positive patient who has already been ACE and ARBs, there was initial some observations, later there was some different observations. So what will be your take, Dr. Mukul? Will you like to continue ACE and ARBs in a patient who has been found to be COVID positive?
Sir, definitely yes. Guidelines, although there were controversial issues, reason being like the virus which this enters our cells like lung alveoli through ACE2 inhibitors, ACE2 receptors. So the issue is it came in a it was there is a study in 2005 not on human, it's an animal study which showed that it can like if we use ACE inhibitors or ARBs, then this pathway RAS pathway is blocked, then these ACE2 inhibitors are increased. So they may increase viral virus entry into these cells, and which can increase viral load and its further consequences.
But lately
But
they have
there
been
is,
allowed to be
yes,
not
sir.
significantly, can be continued as it is.
Yes, yes. So now the data say that they
Dr.
can be
Raghavan,
continued.
will you like to talk about this controversy? Say something about
See,
ASMR?
as Dr. Mukul told very clearly, the thing was we are basically dealing with beta type of COVID virus. So what thing is, if you compare it with SARS-CoV-1 virus, it had got a spike of S protein which was binding to these ACE2 receptors, but it is binding very, very weakly to these ACE2 receptors, as to the virus which we saw in 2004. So I do not think there are much evidences and there are much studies which are saying that ACE inhibitors should be discontinued in these patients, because as far as the off-late studies and the data which have come up and the mechanism it shows that it is very weakly linked to ACE2. So I do not think that it is the right mechanism through which the virus.
So our consensus is that as per today, all of us agree that we may let the patient continue ACE and ARB, and it's not going to make him more prone for the fulminant viral infection. Dr. Pancholi, I have a question. Yeah. Yes,
Yes,
sir.
can I interrupt here?
Yeah, please do.
Apart from that, in fact, the ACE2 actually responsible for conversion of angiotensin 2 to angiotensin 1/7, which has all the preventive characteristics like vasodilatation, anti-proliferative effect, anti-inflammatory effect, anti-apoptotic effects, all the beneficial effect because of the ACE2, which is converting angiotensin 2 to angiotensin 1/7. RAS blockers, and we also seen that there is in fact a down regulation of the ACE2 in the lungs, which causes more lung injuries. So by giving RAS blockers, we have dual benefits, not only blocking the angiotensin 2 and having all the cardioprotective effects, but also upregulating the ACE2 and more conversion of angiotensin 2 to angiotensin 1/7 and have all the beneficial effects. So the RAS blockers have a dual benefits here, and on that basis, all the international society guidelines are recommending not to discontinue ACE2 or the AC inhibitors or ARBs in those patients who are already on ACE inhibitors or ARBs.
So what is Dr. Pancholi, what are the international societies guidelines on RAS?
The International Society of Hypertension, European Society of Cardiology, American Heart Association, all recommending that the patients who are on RAS blockers should not withdraw their RAS blockers if they are on those. And there is another study which clearly showed that those patients who discontinue RAS blockers, the mortality rate was 9.8%. As compared to those who continue RAS blockers, the mortality rate was 3.5%.
Fine. So I think we have a consensus that if patient is on ACE or ARB, I think we should continue them, and it is not going to harm him anymore, but it should be beneficial.
In fact, the consensus, sir, is that whatever antihypertensive they are taking, that should continue rather than changing. I think that is also the consensus from the guidelines. Yeah. And the ACE2 in particular is a theoretical and experimental controversy, not clinically proven.
Yes, correct.
Yeah, very good. Now, Dr. Mukul, there's a situation recently, like suppose any patient ends up with acute MI and who is tested to be COVID positive, what is going to be cardiologist's take on? Will you be going for thrombolysis or will you going for PT like primary thing? What do you think about it?
Basically, sir, in pandemic, we should think of do no harm to ourselves, to our staff, as well as to the healthcare system. So if the patient is having acute MI, he's within window period, then definitely thrombolysis is the best option. And if post thrombolysis patient is having remains hemodynamically unstable, have cardiogenic shock, or it is a failed thrombolysis, then it becomes indication for intervention. And moreover, in that also we should think of of our setup, whether in our setup we have so many healthcare workers like lab technicians or staff, sisters, so that if a COVID-19 patient comes, they can go in quarantine after that or not, and we can run our emergency services smoothly or not. All these decisions, and patient will also come late. There are more chances because of this lockdown situation. All these there is the difficulty in coming to hospitals also. And moreover, in hospital, if we have proper all those in cath lab negative pressure ventilation, or we have adequate number of PPE kits or these N95 or FFP masks, only then we should go ahead with intervention.
I think well said. What is your take, Dr. Raghavan?
So as per, if you go by what the recent ACC/AHA guidelines are recommending, first of all, the best is to thrombolize the patient, observe him for a period of 24 hours. And if you see that there are no symptoms, in the meantime, you can send for COVID tests also. If they are negative, and then you can next day proceed with intervention. One thing is that in patients, yes, of course, who are not fit candidates for thrombolysis, we do see a lot of patients. It is always better to see your setup first. Do you have a proper isolation ward? You have proper materials with you. If not, it is advisable to refer to the next best higher center where all these facilities are available, so that you are taking care of your staff as well as your center, as well as the whole system doesn't collapse. That is the point, sir.
I think what well said, Dr. Pancholi, probably you'll agree that it is better to go for thrombolysis unless it is warranted and it is not responsive. It will be better and safe. Dr. Raghav, just tell me one thing. There's been a feeling that COVID-19 infestation predisposes or there's an increased incidence of cardiac problem or arrhythmias in COVID-19, especially there's a risk group. Do you have some observations on proneness of cardiac events or arrhythmias in a high-risk patients with the COVID-19?
So the thing is that so please you speak, sir.
No, go ahead. Please go ahead. Go ahead.
Okay. So the thing is that there has been some papers from Europe, Italy especially. So what they say is that as such, COVID is not causing classical. What is the classical problem? What we are facing with COVID is myocarditis. But they are saying that there is no documented evidence of myocarditis. Definitely, it is causing acute myocardial injury, which they are saying is being elevated in patients with in the form of elevated troponin T. And certain patients they did come across in which they found they had a presentation like acute myocardial infarction. That also they categorized into two categories. The first category was the rupture of plaque might be one of the reasons what they proposed. And second, what they proposed was demand-supply mismatch. As far as arrhythmia is concerned, including myocarditis, they said that it was not biopsy proven, so they were not sure. Arrhythmias, they are saying is attributed to the other associated organ dysfunction and dyselectrolytemia or some sort of imbalance which is happening, which is leading on to death in these patients. So clear cut, nobody is clear whether is it really causing a myocardial infarction or is it causing a myocarditis. But what is clear is since they have found elevated troponin T levels, that these patients might be having acute myocardial injury. That is what.
Dr. Pancholi, what is your take on this?
Yes, the reported incidents from this initial reports from China, the myocarditis has been reported in 7 to 17% of the patients, and it is basically because of the cytokine storm and more inflammation. Arrhythmia is also related to the same reason and also because of the metabolic disarray. And that was reported in 16% of the patients, while heart failure has been reported in 23% of the patients. And those who are already existing have heart disease, they are more prone to that problem. And even the plaque rupture because of the inflammation and cytokine storm, the plaque rupture, and they present with acute coronary syndrome. And as Dr. Arel pointed out, how to manage these patients, we have to go ahead as per the guidelines recommendations.
Yes, I think you are very correct, Dr. Mukul. This is true that all COVID patients, especially senior citizens, ECO has been the integral part of our investigations, and we have been coming across some or other these cardiac issues, and it seems that definitely there's some inflammatory issues. There could be the proneness for cardiac issues, and I think we need to be very careful about cardiac complication in prone group. What is your take on this, Mukul, Dr. Mukul?
Definitely, sir. Age-related, in prior studies, we have seen that case fatality rate is just 0.32 in less than 60 years of age, and it's 6.4% in age more than 60. So definitely in old age and with other comorbidities, risk of COVID is more. And Moreover, like Dr. Pancholi and Raghav has already discussed that in patients who have prior CAD, in those patients, the case fatality rate is more. It's around 10%, and they have seen that patients who have died, in which they have around 10% have CAD and around 4% have heart failure or this
Yes,
myocarditis.
one thing is sure that this brings about a cytokine storm. There's a lot of inflammatory markers, and probably they could be aggravation of underlying CAD, or they could be element of myocarditis, etc. Dr. Parikh, you wanted to say something?
Yeah, I want to say something because there is, acute myocardial injury and rise in, the enzymes. So sometimes first ECG, we may not be able to say whether it is myocardial infarction, acute coronary syndrome, or it is the, myocarditis and, damage to the acute injury to the myocardium. So maybe serial ECGs may be able to say whether, you may be able to say whether it is classical myocardial infarction or is it a myocardial injury due to the COVID case. I think that may be a point to note. Or
you are absolutely correct, Dr. Parikh. Now, one important our observations, our practice, and I would like to share with you that ECG and echo are the integral part of the initial investigation of all COVID-19 patients, more so if they have comorbid conditions or more so if they are 60 plus, because we have been finding out the ECG changes and we have been found the changes of ISD. Now here comes a very interesting situation I'm posing to all of you, that recently there was a nice article in New England Journal. They did the autopsy of 50 of the dead bodies and they found out that there was a thromboembolic phenomenon. I would share with you that we have been also doing, I think all moderate to severe patients, we have been finding out the positive D dimer. We are getting the quantitative D dimer and FDP, which is very high. We are finding the interleukin 6, which is very high. And we have been doing prothrombin time, which was also very high. So three of the important parameters we have been coming across was these inflammatory markers we are finding out. ECG also showing certain motility disorders, which we have been coming across. So what is the take of this? I checked a lot of literature, not very many studies, and it has not come on up-to-date app or something about role of low molecular weight heparin preventively or patient with probable exposed or probable comorbid conditions. So I would like every one of you to talk about in a situation of thromboembolic phenomena as a cause of pulmonary injury. That paper also speaks that the cardiac, the pulmonary shadows on CT is not because of viral pneumonia, because of pulmonary infarction. So what is everyone's take on low molecular heparin, like in prone patient or such patients or cardiac symptoms in the COVID-19? Start with Dr. Pancholi.
As per the recent report from WHO, they pointed out that low molecular weight heparin to be started initially, and particularly when you come across VTE cases, venous thromboembolism and microemboli. So low molecular weight heparin, they have definitely recommended for
But
that.
Here I must share with you, Dr. Pancholi, not very many trials are supporting. We did echo of almost 50 plus patients. In none of the echo we found any evidence of pulmonary embolization, although all these patients had markedly raised D dimer FDP. Then we checked the literature and it mentions that if baseline D dimer is raised by 4 to 6 times, think of LMW. If platelets are less than 50,000, you may use LMW. So what has been your thing? Because not strong literature favoring the LMW in cardiac prevention. These.
After this New England Journal the report, I have gone through the literature, and they have mentioned it was a JACC journal recently published. So they have mentioned about the recommendation for the initial to start with the low molecular weight heparin, and followed by this direct oral anticoagulants to be started after that at the time of discharge.
Dr. Mukul, what do you think about it?
Sir, like as you have told, I'll agree with you that we can avoid. There's no strong evidence to start low molecular weight heparin, so we should avoid.
You avoid. You will not recommend low
Yes, sir.
molecular heparin. Yeah.
Yes.
What is your take, Dr. Raghavan?
Sir, if we go by the basic concept, like what is the reason which is precipitating thrombus formation? Because I was looking for the reasoning why these embolic phenomena are happening. So one of the reasons which can precipitate them is hypoxia per se itself, which is associated with virus, number one. Second is it seems it infects your red blood cells and causes a lot of iron to be released, which is also responsible for causing the damage to the body systems as well as the endothelium. So there is no harm in starting them on low molecular weight heparin, going by the basic concepts of thrombus formation in the body. And of late, there has been a lot of studies from America, where they have also found an evidence of arterial thrombosis and almost 7% increase of stroke in these patients. Exact reasons for that is yet to be determined. Even in China, they found that 5 to 7% of the population did have an evidence of stroke. So I feel there's no harm in putting them on an anticoagulation.
What is your opinion, Dr. Raghavan, on that concept of the hemoglobin iron getting released, causing the oxidative
This
damage?
is one
Like
of the proposed, yes, one of the proposed mechanisms through which the virus is causing the damage. What it is being that it is causing your neutrophil count to get decreased, and it is destroying your RBCs and leading to increase in the iron load in the body, which is having some, which is getting settled and further causing the damage. That is one of the proposed mechanisms in one of the article I was reading, they have, through which the virus is acting. That is the reason why they said that like chloroquine also came into the role through the same mechanism, but I'm not sure whether it is exactly a documented mechanism or not. So going by this mechanism of hypoxia and thrombus formation, and as we have shown the evidence of stroke, I think there's no harm in using low molecular weight heparin and can be considered in these patients for sure.
In a guarded manner, it is worth thinking. Could be over the period of time and more autopsies happen and we document. In fact, we also started a study. We have been doing CT, and the pulmonary CT angio we could be enriched by next 2 days, which really happen to about it, which is very important. One of the very interesting situation. Now let's talk about the treatment part. I would like each one of you talk about that. Hydroxychloroquine was a first drug. It has definitely antiviral effect. It is a drug only meant for an initial situation. It is not a main drug. You got my point. It is the initial drug to reduce a viral load. It is not it is a supportive drug, or I would say it is a drug to begin with. You cannot give total credit or discredit to this drug alone. But when you don't have too many things in hand, you have a drug which is well tested in hundreds and lakhs of people. Probably before in my lifetime, probably same with you, before this COVID, we never got a ECG and QT interval measured of any drug who was on even regular high Q, except they talked about it. So we have been using this hydroxychloroquine in the initial stages, and probably patient has been tolerating very well. We did not find QT issues in any of the patient except 2 patients out of almost 600 patients plus in which we used so far, who were known case of ISD, and it was started. And these patients also did not have any symptom. Only on the ECG we discovered that the QT interval has become more than 0.5. Then we stopped it. So what is each one of you opining about the hydroxychloroquine and especially the cardiac safety? Then talk about the efficacy of it. Dr. Pancholi?
What I feel, the patients who do not have any pre-existing cardiac disease and not on any cardiac drugs, we can safely start hydroxychloroquine in them. But those patients who are having pre-existing cardiac disease on drugs, so it is better to check QT interval prior to starting hydroxychloroquine and then start.
Here I will interrupt Dr. Pancholi. Everyone talks about cardiac, non-cardiac patient and hydroxychloroquine. I must share with you that 80% people are young and asymptomatic or mildly symptomatic. 15% people are moderately symptomatic and comorbid conditions patients which can have. So if you look at this, the cardiac patient in the whole spectrum of the disease is very low. You got my? So what is happened is 1:1. Everyone talks of cardiac and non-cardiac. So if you look at the population at a large, doesn't fall in the contraindicated group. In fact, population as a large falls in the indicated group. So any drug which we give, I'm not trying to that any drug we give, like for example, you give amikacin, we know that we need to be careful about creatinine clearance and creatinine. We always don't say that give amikacin, just watch for, like we know that it has to be given carefully a person with a compromised renal function. So probably the group which is eligible for this drug, which will tolerate it, I think is very big. What is your take on that? Dr. Pancholi.
Yes, in those situations, we can safely give that drug because the majority of the patients are asymptomatic and do not have any cardiac ailment. What I'm telling, the patients who are on certain cardiac drugs which are responsible for prolonging the QT interval.
Yeah, they should be
suppose,
avoided.
for example, patient on Omidron. So in that situation, you have to check QT interval prior to starting hydroxychloroquine and go for the safety issues.
No, I am saying that if the patient has underlying cardiac problem or with the drugs which can affect the condition, better we can hold it also. But that group of people is a very less in number. So that is a very important thing to talk about it. Dr. Mukul, what's your take on that?
Sir, like ours is also a COVID hospital, but as number is very less in Himachal, and we have seen around 30 patients, and except for one, all were asymptomatic patients. So as a protocol, we get ECG in all the patients, and we have not, baseline was all right in all the patients, and later on after HCQ also, we didn't had any increase in QT.
Dr. Raghavan?
Sir, even I believe in the fact, see, basically the role of chloroquine, as per going by literature, was more in coronavirus associated pneumonia. And as we are also dealing with most of the patients who are not having much cardiac problems. And we have started them on chloroquine and we have been monitoring them so far. So,
secondly, don't you feel so that the doses which you have been giving and the duration for which we have been recommending, is it too small to have any of the issues? And
absolutely.
especially, we have not seen very many 25% rise in QT interval, etc. We have been very careful. I must tell you, initially from France, there was a very favorable studies of azithromycin plus chloroquine. In fact, one of the studies shows that if you combine two, the viral negativity became almost double than it being given alone. Although we were very careful about QT issues, but we truly speaking didn't come across. What is your take on this combination on QT interval?
See, that again, I would say if you are having a so far what I've seen is basically your azithromycin is again an enzyme inhibitor. If you see,
Yes.
it is one of the drugs which has the least interactions and least inhibiting effect of the other as compared to the other two drugs. So what I feel personally is that though I haven't tried this combination here, but I do not think there should be much effect on QT, even if you combine the two drugs.
Dr. Pancholi, on this combination, what do you say about it?
Combination of azithromycin, hydroxychloroquine, if the patient on some antiviral drugs also, then there might be problem because the certain antiviral drug protease inhibitor, they are responsible for QT prolongation. So yes, we have to careful combining.
You are very correct. I think you're very correct because those drugs are very important. But azithro with SCQ, there has been studies, but not truly. But other antiviral drugs like lopinavir or ritonavir have been found to be associated with QT interval. In fact, the test book mentioned torsacidity pontis also, or WPW syndrome also, but we didn't come across. But what you say, alone chances are less, but if you combine with antiviral drugs could be very good. Here, I have a feeling, I must share with you that diabetes is a precursor for all cardiac complications. And all COVID-19, we found the sugar going busser. Especially we had few type 1 diabetic patients and their chances of going into ketosis was very high. So I have a feeling that we need to have a perfect diabetic control, perfect to prevent the ketosis also and more frequent sugar monitoring because these patients also more prone to have the cardiac complication, which is we have been there. You must be handling a lot of diabetic cardiac patient, Dr. Pancholi. What is your take on that?
Diabetes should be controlled very well in this situation, and we have to avoid ketoacidosis in that situation. So there was a discussion initially that should SGLT2 inhibitor to be given as an add-on therapy with other drugs or not. So the opinion is that we have to avoid SGLT2 inhibitor in that situation and continue with other anti-diabetic drugs for the control of diabetes. But as you are more expert than me, so I need to know your opinion about that.
I think we have been very careful about diabetic control. All of the COVID patients, because of lack of activity, because of the stress, because of cytokine, there has been dysglycemia, and patient might go into more frequent hypos or hyperglycemia, and we need to be very careful about it. You need to give a cardiac safe drug. Insulin is a good drug, but with a close monitoring, and it is also prerequisite for a good cardiac control. Here, I must share with you, all of you, some data that look at the example of Spain or the France or the USA, that mortality has been so phenomenal. If I share the facts that Portugal and Spain share the land, they are the adjacent neighboring countries. The deaths in Spain has been almost 100 times more than the deaths in Portugal. And if you look at this, 70,000 plus deaths in Spain, while Portugal had only 700 deaths. Portugal is the only European country, like South Asian countries, etc., who have been taking BCG vaccine. So we have also started a trial, the immunity given by this Bacillus calmette-taurine vaccine. And this example of adjacent countries, Portugal having practically almost 1/100th of the death, morbidity and mortality profile than Spain. And same, I think, although the lockdown and although the isolation, all have helped us, but probably this also has been protecting us. So what is your opinion on this, Dr. Pancholi? The BCG protection which our country is getting.
That is an area of discussion nowadays, and it has been well said that because our country having a BCG vaccination, so they are probably immune to this COVID problem much more. So, but I don't know in details much about this.
Okay, fine. Doesn't matter. But one thing I can tell you, we are lucky to have this protective phenomena, and the viruses seems to be the less virulent, which is very important. Another very important question which is coming is, what should be the protection for the elderly people or the cardiac people? What will you strongly recommend in this present era? What will be your protective advice for the people with the cardiac condition, hypertension, diabetes? How should they protect, whether they are 60 plus or not 60 plus? What will be your advice to them?
All those patients with cardiac disease or having comorbidity should stay at home, should be well isolated, and keep this physical distance, and all the protective measures which are actually recommended by the WHO and ICMR, that is to be followed by all the elderly people.
Dr. Mukul?
The people should understand that like if they have curfew passes, that doesn't mean that corona will not affect them. So they should stay at home. That is the only message.
Dr. Raghavan?
My message is very clear. One is diabetes itself is an immunocompromised state, so they should stay at home, follow a healthy lifestyle of living, and at least they should isolate themselves, go for at least 30 minutes of exercise in their home, whatever way they can do, and keep them physically active, and a good healthy diet should be a good option.
You're absolutely correct. I think all of us should ensure that our diabetic, hypertensive and cardiac patients should continue same medications. Only thing is that diabetic patient may require some adjustment of doses because of changed food habits and lack of activity, etc. But their proneness to the COVID infection continues to be very high. Secondly, few of the facts, I'm sure all of you know, but since we are handling a huge number of COVID patients, I must share with you that this COVID-19 virus, once it comes out of the droplet, it stays in the air in the form of droplets and falls down on the formators, and it stays on the solid surface from 2 to 9 days. That is the duration. We need to be very careful to understand that it stays on the formators for 2 to 9 days, and we need to be very careful about the frequent hand washing. Number one. Number two, the masking is most important. We should follow the Israeli pattern. What the Israel has done, that all the senior citizen patient with a high blood pressure, cardiac problem, and diabetes, they've locked them inside. So I think we should also encourage, and telemedicine consultation should be our best thing which we can do about it, and which is very important. So if we look at this management of the other cardiac issues, like what is the risk of other cardiac complications? If you see anything like is chances of pulmonary embolization or pulmonary hypertension or any other cardiac complication which you foresee in COVID-19 patients, or any other which is rare thing, or deep vein thrombosis or anything, Raghavan, you think that they are prone to or predisposed because of cytokine storm or any complication you foresee in a cardiac patient, and you will think that you will put a prophylactic note on that. Dr. Raghavan?
Sir, apart from, as far as so far what we have seen, as we have already discussed, that apart from myocardial infarction, myocarditis, and arrhythmias, I do not think there is any other documented cardiac problem, and that too, what they have documented are not very clear whether it is really a myocarditis there, or they are really having a plaque rupture, or is it a demand supply mismatch which is causing. So it is very difficult to comment about other situations, because we are not seeing such type of things in these patients. To be honest, no, I don't think any pericarditis or any other thing or any device infection or anything has been reported in these patients so far. So,
Dr. Mukul?
I think Raghav is right. So, but we can advise patient to do not remain totally sedentary and at home also, and they can move around so that incidences of VT and all those things reduce, and deep vein thrombosis and all those reduce.
Dr. Pancholi?
Apart from this main cardiac elements, the venous thromboembolism has also been reported in some of the cases, and they are recommending the prophylactic use of this anticoagulants or antithrombotic agents in the form of heparin, and followed by this neuro-oral anticoagulants.
Correct. If we come back to SCQ, what has been your observations about giving it to health persons, that those who have come in contact, and new guidelines of government India has come now, that those who are asymptomatic COVID patient or those who are mildly COVID patient, they can be home quarantined. And those people who are home quarantined, who are asymptomatic or mildly positive COVID patient, all their contact should be given to given hydroxychloroquine, and which has a meaning. So what is your advice is it a perfect suggestion? We should go for hydroxychloroquine for all the contacts of the patients, other than health professions. Health professions are very well recommended. Now the new guidelines of Government of India says that if asymptomatic or mildly positive home quarantine, then all the caretakers at home should be given hydroxychloroquine. What is your take on this?
Those who are at home, so those who are at home and they are home stay and not in the contact with any positive COVID patients, there is no recommendation for taking hydroxychloroquine in them. Only those who are in contact with a positive COVID patient, lab positive COVID patients, they should take as a preventive measure the 400 milligram BD on day 1, and then 400 milligram once a week for 3 weeks. That is the recommendation by the ICMR.
Or the patient who have been quarantined at home, their family members can take it who have been coming in contact. What do you feel, Mukul and Raghavan? Dr. Mukul?
Sir, but I feel like the relatives who are staying with the patient, only, I'm not sure, because we do not have any other option, so we are giving, but only those who are prone, like elderly or those who are having some comorbidities, they should take, not all.
Raghavan, now one of the very important things, some of the patients with comorbid condition have been going into respiratory failure, and we have been thinking of high flow oxygen. We have been thinking of BiPAP. We have been thinking of invasive ventilation, and there is a concept of proning also. Make the patient prone also. So, what is your advice on a patient COVID-19 becoming hypoxic? So, how do you feel about that? There's been a lot of studies that make the patient prone totally, which improves the oxygenation and improves the oxygen saturation. Dr. Raghavan, what do you say about proning in the failing respiratory system in the COVID-19 patient?
Proning is one of the last resorts. Usually we prefer in patients who are going into a end stage of acute respiratory distress syndrome. So in these patients, if they are going into such a stage, that means they have a full-blown pneumonitis or acute respiratory distress syndrome. So we can try with the pruning position, but I am not sure how much it is going to benefit, because
you follow the same protocol: first high flow oxygen, then BiPAP, and then invasive ventilator.
Absolutely, sir.
Yes,
Yes, definitely.
I must share with you, the check with BiPAP is that the droplet infection is spread with the BiPAP. So one needs to have all the protective gear, etc.
Absolutely.
And early oxygenation is very important. Here, I would like to share with my colleagues that even if someone has an oxygen 92, 93, we have a lot of patient, but if you find the falling pattern of oxygen, that which was without oxygen 98 before, it was 96, now it is 94 and 2. The falling oxygenation is also one we need to be careful about it. We need to go for high flow oxygen, and we can go up to 10 to 15 liters per hour or up to 20 liters per hour before we think of BiPAP. And invasive ventilator is a time when you feel that irreversibility is there, and we need to be very careful about it. And we are not so happy and excited about the invasive ventilator, which is very important. And I think, if possible, that's a stage of no return about it. What is your opinion, Dr. Pancholi, about these respiratory maneuvers which we can offer to the patient with COVID-19? Dr. Pancholi?
Yes, yes. We have to follow what the routine measures we are following in other patients regarding the respiratory care. So, and regarding the proning, in a few of the hospitals in United States, they are following the same regime of proning.
Yes.
Not at the end stage, but right in the initial stage
Well,
also.
early also they are following
Early
the
also
proning.
they are.
Here I must share with you, sir. In our management, I would like to just show you a small picture of preparedness of our hospital. What we are doing, 80% of patient we have no risk at all, but 80% have no issues at all. But 50, now I'll show you. Okay, before I come, I'll show you the preparedness of our hospital, which is housing almost 558 patients on today, with 36 patients in ICU, and we have a huge team, and almost 120 resident doctors are on 8-hourly duty, with almost 45 faculty members who are round the clock duty. And probably this is a way which we have been working on. So that's just to give a feel of our hospital. There's a infectious disease is a ICU. That's a, please keep flowing. I would like just quickly flow to, this is our, this slide shows our suspect, where we get the suspect. We have created the separate partition so that we don't know whether they are positive or negative, and we send them. After coming positive, we send them to the main hospital. So these are the blocks. We've got the suspect. We have a capacity of 150 suspects by these partition. We have got 4 dialysis centers. The renal failure is very common in COVID patient. So we have COVID positive dialysis. We have got COVID positive with hepatitis B, COVID positive HIV, and COVID positive hepatitis C. Can we go for the next quickly? We can go for the, these are the arrangements we have. 1,000 bedded hospital we have. Next, you can keep circulating slides very fast, just to give a feel to my colleagues. Quickly, you can roll it, sir. That almost 120 resident doctors, or this was a, these were the pictures taken before the occupancy of the patient as a preparedness in the last week of February. Next, we can go for, next, we can keep going. We can keep going, sir. We can keep going. Like, and 1,000 beds, keep going, sir. We have added for COVID patients. They are all full now and with 120 residents on the round the clock duty. Can we go next? Yeah, so I'll close it down, sir. So that's the way what we have been doing. We have given a pulse oximeter. We have got almost 1,000 pulse oximeter in our hospital. We give it to each of the patient. More so, people with the hypertension, diabetes, and cardiac patient, we give them a chart and they keep recording. 60 to 70% are sensible and literate. They keep recording their pulse and oxygen levels every 3 hourly. If there's a tachycardia or if there's a falling saturation, we keep talking to them on phone. So this is the way I thought I must share with you the way we monitor our patients to reduce. And we have employed robots in ICU for reducing the contacts of the patient, for delivering the medication, for delivering the food, tea, etc. Probably you don't have a slide which I kept for robots. So that's the one which we have been doing. So oxygen saturation is one of the important parameter because hypoxemia is one of the important thing. And what is your opinion, Dr. Panchuli, about hypoxemia monitoring in COVID-19 patients? Hypoxemia monitoring with pulse oximeter.
You have to regularly check with the pulse oximeter, and if it 90 saturation, then of course you have to get a supplement with the oxygenation.
That's, I think all of you will agree. And
Yes.
before that, I'll just ask Dr. Pari, could you enlighten us some newer trials, newer studies which has been supporting hydroxychloroquine? Because what I feel that till the specific drug, the effective drug, the strong drug comes in the early stage, it is worth trying. There's something to try if you can reduce the viral load, viral suffering, and viral lung injury. So, Dr. Parikh, will you like to enlighten something more on SCQS?
Yeah, thank you, sir, for giving me the opportunity. So, what I feel is that looking at the profile of the drug is may not be direct antiviral effect, maybe playing that much role as compared to its other effects like inhibiting the cytokine storm, reducing the cytokine storm. So when we give it at early stage, the drug is beneficial. But once already the cytokine storm is well established and it is a severe stage, probably the drug at that stage may not work. So some of the early studies which showed that the drug is not working is where already the patients are in serious condition where it may not work. And so far, when it comes to evidence, I think so far still there is no drug in sight. I think remdesivir also, the trial which Gilead Sciences was after that, but that results were prematurely leaked by at WHO, and then it showed that the drug is not working, although one trial showed it is working. So still we, from the standard of randomized control, large-scale trial, we don't have any trial with any agent so far. But hydroxychloroquine, there are indications that it is working at, particularly at the early stage, it is working. So it is very important that this usefulness will be there. And other point I want to say that India is the only country where hydroxychloroquine is approved as an anti-diabetic drug. So this is where when you have type 2 diabetes uncontrolled diabetes will again interfere with the outcomes as I think you would agree with that. So hydroxychloroquine would also play a role in uncontrolled diabetes, making it more controlled. So you need to adjust the dose of insulin, etc., and you need to monitor the condition, the glycemic profile of the patient. Other thing is that when we are discussing about the microthrombi, release of microthrombi, and what is shown here is that there is a combination of intense inflammation along with thrombosis. So this thrombosis is slightly different from other thrombosis which you see, is that there is intense inflammation as well as there is thrombosis. So in this setting, when you give a drug which is anti-inflammatory as well as anti-platelet, platelet hyperreactivity has been shown in COVID patients, and antiphospholipid antibody positivity also has been shown in some case reports in COVID-19 patients. So hydroxychloroquine also works in antiphospholipid antibody positive patients to reduce the thrombotic events by the virtue of its antiplatelet and antithrombotic effects. This may not be known to many people, but this is also a part of the drug when you use the drug in lupus as well as primary antiphospholipid syndrome, not only just secondary antiphospholipid syndrome. So this is where it is getting usefulness. There was one trial of 150 patients in China where it was randomized controlled trial where 75 patients received hydroxychloroquine and 75 received placebo, where it reduced the duration of illness and reduce the progression of the disease. That's where, so possibly it will reduce the complications when you use it early stage. That's what is the feeling here. But as yet, we don't have any firm data. But if you permit me, I would like to talk on safety of hydroxychloroquine a little bit.
Sure. You should. In fact, yeah, it is important from cardiology point of view because everyone talks, they're so scared, and especially all those who are scared are not used it in profusely. So talk about the cardiac safety.
Okay.
Very important.
So what I wanted to say about the cardiac safety is that there is, recently just one trial came from one study came from University of Florida, where this drug is not a new drug. It is there for more than 50 years. It was approved in US FDA in 1955. We got it approved, first approval in 2001 November. I got it approved for rheumatoid arthritis. So India, the first approval was, but other countries in US and Europe, it is there for more than 50 years. So University of Florida, investigators looked at the safety database of last 50 years from 69 to 89. The study was just published last week. And they showed that, almost more than 13 million patients were exposed to the drug, and they didn't find any QT prolongation signal with hydroxychloroquine, but they found that signal with azithromycin, much more higher signal with azithromycin, and a combination of azithro with hydroxychloroquine. So with this, the signal is more with azithro, and that is why it is coming with combination of azithro with hydroxychloroquine. Other thing is when you see the label of the drug, as you call it, pack insert prescribing information. When you read a non-prescriber, when he reads a US FDA label, the common adverse effect of nausea, abdominal pain, which occurs in more than 10% cases, versus an adverse event of cardiovascular nature, you find that a non-prescriber will not be able to differentiate. But when you look at the European pack insert, European prescribing information, EMA, they have divided all adverse event into very common, when the frequency of the adverse event is in more than 10% patients, common less than 10%, uncommon less than 1%, rare less than 0.1, very rare less than 0.01, and so on, and then unknown when you don't know the frequency. So cardiac adverse events in this European prescription very clearly come in the rare and very rare category. So that's one very important to point to reiterate. And as such, before this COVID, there was no in the prescribing body, there was no mandate to do ECG in all patients before starting hydroxychloroquine. Ophthalmic examination was a mandate, but not take ECG and then only prescribe. But in the era of COVID, it is better that ECG can be taken easily. So once you take an ECG, rule out conduction disorders, rule out underlying cardiomyopathy if you see a ventricular hypertrophy pattern. So then that can be ruled out, and then you can, when the patient is in hospital, you can always monitor that. But otherwise, cardiac problems have been very, very rare situation with the drug. So that's what I wanted to reiterate, that the signal has not been found in a last 50-year study with University of Florida. They didn't find QT prolongation signal with the drug, although individual case reports may be there. But as such, the signal has not been found. So this was an important thing I thought I will share with you.
You are absolutely correct. Having tried hydroxychloroquine in initial stages of COVID-19 patients, we have been doing, could be another 2 months or 1 month we'll be able to give you. We have been doing interleukin 6 levels in many of the patients. That what happens to interleukin levels, because we have been doing it initially and before, once the patient comes out to be COVID negative. So in hydroxychloroquine group and non-hydroxychloroquine group, we are also trying to correlate, because so far in Jaipur, we have got 600 plus patients who have become COVID negative. So what was the effect of this initial uses of drug in the duration of negativity? Our average duration of negativity of asymptomatic or mildly symptomatic patient was 8 days. So we are analyzing the data. Has this drug, having given initially, made a difference, and it has brought down the average to 8, otherwise it would have been more. So could be like that. But yes, in collaboration with you, we are trying to do a cytokine panel, and so I'll discuss you later. But yes, as far as my cardiac colleagues is concerned, I have a feeling that sharing our experience, this drug is being used in quantity in tons, and cardiac evaluation was not a mandatory, in fact, before for any other reason, except that after particular duration of time, one need to have an ophthalmic checkup, and during course also you need to be very careful of ophthalmic side effects. And that too also Dr. Pari could agree, cumulatively when you use it more than 1 kg of hydroxychloroquine, which comes out in 7 to 10 years, then there is a risk in very few patients. So I think keeping in mind that it is not a main drug to be labeled as or to be discarded outrightly, not a main drug, but yes, to begin with, if we can improve the parameters like inflammatory markers, like antiplatelet effect by reducing the little viral load, changing the pH and viral viability, it is a worth considering. Now, combination with other drugs, I think it's just a duration of time which will reveal that how good, how safe. But as on today, as I said in beginning, every tilt falls in favor of advantages vis-a-vis side effects. So it's worth considering this and that. And at least once it is being talked about as a prophylactic drug in health workers and all of us, I'm sure all of you have taken Dr. Mukul and Raghavan. So it gives you some sort of belief that over the period of time we'll be more confident to establish the usefulness of this anti-inflammatory, antiviral, anti-platelet effect.
I have a small question to you, if you don't.
Yeah.
How many patients in so far which you are treating have you seen there is a drop in hemoglobin in these COVID-19 patients?
To be honest, there was not significant drop in hemoglobin, but we have been finding out altered lymphocyte neutrophil ratio. All these patients have lymphopenia, and the ratio of CD4 to CD8 is altered. We have been doing so significantly. Hemoglobin fall has not been there. The hematological abnormalities we are finding in COVID patient in critical are low lymphocyte up to 8 or 10 or 15%, and the ratio of neutrophil to lymphocyte is all going in favor of it becomes more than 1:5, 1:6. And we have also been finding the altered ratio CD4 and CD8. CD8 is decreasing among lymphocyte also. All in hemoglobin is not. And in some of the patients, another hematological abnormalities we come across is D-dimer rise, FDP rise, prothrombin rise, and we are at fix. In fact, to be honest, that's why my reason of asking, we have not started using enoxaparin or LMW in these patients because we consider up-to-date app as one of the important latest world conclusion. We have up-to-date in our institute. We have been finding sporadical articles of using LMW, but few of the articles mentioned, I would be very happy to have your input, Dr. Raghav, that if a D-dimer rises more than 4 to 6 times with thrombocytopenia, that is an indication that we should use as a LMW, and more so, otherwise also ICU patients, senior citizen, diabetes, LMW becomes an indication, not as a specific COVID thing. So there are other situations which indicates the uses of LMW. So we are a little skeptical that if other situations are there, we are going to use it. But in COVID, we have checked up the literature. If D-dimer rising more than 4 to 6 times with thrombocytopenia less than 50, that's a LMW. So what you talked about hemoglobin, not a significant marker. The important hematological markers are a rise in D-dimer, rise in FDP, lymphopenia, and increase in prothrombin time and the CD ratio.
So do you think if FDP is also rising, they might be going in for DIC also possible?
Yeah. In fact, DIC has, that's the reason I'm telling you, DIC has been explained. So, as a mode, we checked up, not very many papers are there of pulmonary angiography. So we have started now. We are going to go for pulmonary angio. Echo, we have never been able to document any echo evidence of pulmonary embolization in the critically sick patient also. So we did not find any right pressure changes, etc. in echo or any evidence of, and none of our patient had hemoptysis or symptom of pulmonary embolization. So now we are going for pulmonary angiography. But yes, we could not document any pulmonary comp. Ferritin goes high. I must share with you.
Yes.
Ferritin significantly goes high.
So because what I was reading was one of the proposed hypotheses was this virus is causing a drop in your lymphocytes, as you said,
yes,
as it is affecting your heme metabolism in the body.
Yeah, very interestingly, we did not find theoretically with heme theory and following the iron liberation at the heme, we are not finding the significant fall in hemoglobin. So there's an incongruity between heme theory and the hemoglobin fall has not been significantly there.
Very because one of the proposed mechanisms.
Theoretically, if you have the theme theory, the hemoglobin should drop down and cause a hypoxemia, but we did not find falling hemoglobin as a major issue. Yeah.
Dr. Bhandari, I want to take your opinion on two issues. The use of ACE2 infusion in COVID and use of amiodarone in COVID.
Theoretically, sir, I have not come across any of the literature or much reading about amiodarone in COVID. I would be very skeptical to use it unless a situation which has an indication for amiodarone to be used, because we don't know in a COVID patient how the myocardial conduction affects, how the myocardium affects. So I'll be very skeptical to use such drugs which have an unpredictable effect. And IV ACE2 inhibitor also, it is a very difficult question. Probably I've never acclimatized myself to any of the literatures, and I would like I have not thought of it, but if you can enlighten, I will check more literature and scope about it. One thing I must share with you, sir, that we have started the plasma therapy. In fact, we have got approval of Drug Controller of India as well as the ICMR, and you know the plasma therapy is one of the specific with the adequate amount of antibodies present in the serum. The protocol is that once the patient is COVID negative, after 28 days of becoming COVID negative, we can take the serum, cross-match like just plasma pheresis we do and therapy we give it. So we have started, we have as on today 2 critical patients, one of our professor of anesthesia. He has a big patch of pneumonia. In fact, he is Dr. Farid, who comes from a hot zone of the Jaipur where the hot spot was there. So he is a one patient. We have kept him ready for plasma therapy. We got approvals and all like that. And we have chosen the patients after 28 days of COVID negative. We have subjected him for the plasma pheresis, kept the plasma collected and ready. We might use it because it has been indicated that patient from moderate to severe going into falling oxygen saturation, developing tachypnea, deteriorating with no specific treatment being available. So we have been trying soon in 2 patient plasma pheresis, but both these questions has aroused a lot of interest, Dr. Pancholi. I would like Dr. Mukul and Dr. Raghavan to talk about this, both the therapies you talked about, amiodarone and ARBs. Mukul, Raghavan and Mukul? Yeah.
ARBs, so we have already, I think, discussed. So
no, IV.
No, not ARB, ACE2 infusion.
ACE2 infusion.
ACE2 infusions, I have also gone through one of these studies in which they have given, but obviously large number of trials and more number of people we have to test. So to confirm that, and as this is a new drug, so more and more trials and are needed, and as like you have a very good experience of first-hand experience of treating so many patients. So as of now, so I do not have any experience, and like where the volume is more, only at that place such trials, more trials are needed.
Theoretically, it sounds very logical, but I think please share if any bigger studies you come across. But it sounds very encouraging to prevent the virus attachment.
Yeah. Yes.
So, but it sounds very encouraging. What about amiodarone, Dr. Pancholi?
I read some article. It works in the same manner like hydroxychloroquine works as antiviral.
Dr. Raghavan or anything?
Dr. Parikh, can you?
Amiodarone per se itself has been in long term been associated with pulmonary fibrosis, and I am not very sure it has a very good anti-inflammatory properties as such. But not, I don't think so. Amiodarone will be of any use in these group of patients. So very difficult to say that. And regarding anti-inflammatory effects also. So I'm not sure.
Dr. Parikh?
Yeah, it is actually why it has come is because of the similarity in mechanism, as you pointed out, is because it increases the intracellular pH towards the alkalinity side.
Yes.
And that is why it acts on the autosomes and the lysosomes. So the same way the viral replication would be reduced. That's the theory behind. But practically nobody has, I think, come out with any clinical data so far.
Yes. The only thing is pulmonary fibrosis has been reported with it.
Yeah,
Which
all other side effects will be there, whatever.
I think amiodarone is a drug which is more scary than beneficial effect. You have to be so careful of so many issues with amiodarone,
including hypothyroidism and all those things.
Yeah, so many issues. So I think we'll be very careful to make use of this drug. So I think any your opinion, all of you three, about plasma therapy. And suppose some patient has a cardiac problem, because you will be giving only 200 ml of plasma. So even if it is not as standard wise, all COVID patients need to be on negative balance. Fluid overload has to be prevented, and 200 ml of plasma in one shot should not be a challenge to the cardiac thing. But any of your observations of plasma therapy in COVID-19 patient with the cardiac or the hypertensive patients?
Dr. Bhandari, in the newspapers, in practically all the newspapers, there is a question mark about the plasma therapy by ICMR.
No, sir. ICMR has only given the permission. We are a part of the ICMR protocol, sir. So not a question mark.
So why in the newspaper about?
No. In fact, there's a protocol that the donor should have antibody titer more than 1:60. So there could be, we need to perform an antibody test, the presence of in a particular titer of antibody for plasma to be effective. Otherwise also, sir, I'll give an example. If the patient is DIC, patient is raised FDP D dimer, you can give a simple plasma to overcome the crisis. So truly speaking, you are just giving a plasma which is supposed to have anti-COVID antibodies. So truly speaking, there is nothing wrong about it. We have been using in many of the critical patients. In fact, our first three Italian patients whom we put on hydroxychloroquine, lopinavir, ritonavir, 2 had the complications, and we gave them n number of plasma, not COVID plasma. So basically, the difference is that FFP here and the FFP donor being the COVID recovered patient is that it, in addition to the plasma, it has COVID antibodies. So we are just following the ICMR protocols only. Why I'm talking to you is that there was some literature mentioned about the cardiac overload, but 200 ml plasma with absolutely patient on negative balance should cause any cardiac overload kind of thing. What do you think so?
Of course, we can give, sir. That is not a problem if you are having an adequate negative balance. And I think by going by the mechanism, I don't know how plasma therapy is going to help. Of course, some antibodies may help in decreasing the virulence of the virus.
A lot of trials have given since there's no specific treatment available, and as Dr. Parikh said, remdesivir also WHO has come with other way around. We were so hopeful that this could be a great antiviral drug, but then they have come out with it. So every day, in fact, we keep joking among ourselves that opinions about COVID-19 is like a weather. When it changes, what color it changes, every day the guidelines are changing. So it has been a very interesting.
No, it basically reminds you of Darwin's theory, that survival of the fittest, either the virus, either we will survive or virus will become like common influenza and common cold, what we are getting.
Yeah. But let me tell you one thing, all of you must be talking to friends in different countries. We have alumni in US. Probably we have been very wise having experienced the lockdown so early, such an intense isolation, and it has caused a tremendous personal, social, and economic issues in our personal and family life. But we have been a big gainer. If you extrapolate the morbidity and mortality of Spain and America on Indian population, probably it will be frightening. So I think still I would say in next few years, what advice we have been giving to our being advisor to our government, we have been telling that, sir, it should be like no person on the road, if at all he comes, should be seen without mask. It should be like absolutely fine. No person should be seen like without helmet on the two-wheeler. So masking and containing our senior citizens should be the only thing. And I think all our cardiologists like you have been concentrating on tele consultations. I'm sure that's a need of the hour. Dr. Parikh, would you like to comment?
Dr. Bhandari, this opinion from the cardiologist also. Have you seen a substantial drop in the incidence of coronary events in the country after the lockdown? During the lockdown period?
Truly,
not
sir.
much.
Sir, truly not. In fact, what happens, sir? I don't know. I'll share the problem in our state and city. The people are truly, they are resting. They are not exerting. And probably this is also one of the important thing, that they are almost in a resting mode, the physical exertion which brings about. The secondly, because our hospital is becoming COVID hospital, people are scared of coming here. What is happening in best of the corporate hospital in our state? Today also we had a big VC with our administrators that they have not been entertaining any patient unless get the COVID tested done. Once they come COVID negative, then only they are touching them, otherwise not touching them. So people have been very scared. There is going to be a big ordinance by the government here allowing corporate hospital to start COVID testing and make sure they have the fast PCR machines so that they can do the COVID testing in 4 to 6 hours. The COVID test come and they take the call. Probably in all the specialties, patient reporting have gone down. Like I give an example, OPD in our hospitals have gone to 5 to 10%. What is your experience, sir? Mukul?
Sir, in our hospital, actually, they have made ours is COVID hospital, and they have preventively closed all our OPDs. Only emergencies are open in our hospital. And regarding ACS, we are seeing, I think, whatever we were seeing previously, only OPD has been stopped. So we are not doing any of elective patients, only emergencies are being done. So we are
could be because
the
turnout in the OPDs is less, so we have feel of that procedures are not happening so much. Sir. Yeah, we have the feel of that. Raghavan, what do you feel about it?
So in my setup, like I am in a government setup and we are working there. So we did not have a restriction to OPD because that was the only hospital which was a government. So of course we had a dip of like let's say around 40% or 40 to 50% of our OPD, but the number of cases as well as coronary events are concerned, we have been receiving. And in fact, we have been receiving a lot of patients from outside also who have been thrombolized and then being referred to us because of the lockdown. Probably they would have come directly otherwise.
But it is true. It is the government institutions which are catering all class of the patient. Earlier, with the upper class, which were going to the corporate hospital, because of the non-reception there, probably they have been all coming to the medical college hospital. What do you feel, Dr. Pancholi, about the number of patients?
I have been in association with the various cardiologists during the webinar, and what is their opinion? There is a definite reduction in the number of acute coronary syndrome patients. The reasons you already explained, there is a less stress, less traffic stress, resting, and less of air pollution, and of course less consumption of the junk food also at home.
Yes,
so probably that might...
I'm sure no tobacco, no smoking,
no
all the time on masks, so no tobacco,
yes.
No smoking.
No smoking.
Yes, and above all, I think all of us have started leading a saintly life with no competition of the life at home. So I think we have a stress-free, and all of us have acclimatized. We have a great state advisory group which has epidemiologists with us also, sir, and all of our opinion that we should maintain this isolation and quarantine for next few days more. Sir, I got some printout of some lot of questions have come. So meanwhile, what is your opinion on lockdown, Dr. Pancholi? Please give. And meanwhile, I'll select the relevant questions to be put to panelists. So meanwhile, I'll select some questions from the list I've got. Could you meanwhile comment about your observations on lockdown and isolation? How long we should maintain it?
Lockdown. This is for the first time we are experiencing this and living with our own family. My wife is a gynecologist. I'm a physician and cardiologist. So we are not tuned to stay together several hours in the house. My children are very happy. And now we are busy with the webinars. I think we are now loaded with the webinars.
Okay,
So
Dr. Pancholi, there's
there was a joke in the WhatsApp. He probably will not die of corona, but will die of webinars.
Yes, I know you're very correct. Dr. Pancholi, I pose a good question from you by Ravinder Singh, doctor. How to treat stage 2 hypertension in this COVID-19 situation? Stage 2 hypertension.
Now, see, the management of stage 2 hypertension with COVID or non-COVID, it is remain the same. The stage 2 hypertension, you have to give the combination of therapy. In stage 2, as per the ACCHA and ESC guideline. So combination therapy, and the combination therapy mainly either a ROS blocker in combination with calcium channel blockers, preferably, or with a diuretic. So there is no difference with the COVID
It's
or
the same. Yeah.
non-COVID.
Dr. Mukul, Dr. Vijay Bhaskar Reddy asked, although we have already talked about the thrombolysis role of anticoagulant like low molecular heparin in COVID-19 patients. Dr. Mukul, Dr. Vijay Bhaskar Reddy talks about role of LMW in COVID-19 patients. Can you so Mukul?
In ACS settings, sir, definitely after
he has just mentioned from ACS you become
we have to start LMWH, although we should keep on monitoring these platelets and PTI.
I think Dr. Raghavan, Dr. Neela Choksi says, up to what level troponin will be taken as normal in COVID-19 patients?
See, there is no as such data of troponin available. These are the landmarks. Troponin can be elevated in multiple conditions. COVID-19
there's no limit like that.
There is no limit, number one. Secondly, you cannot blindly go by troponin because it can be elevated in severe pneumonias, underlying renal dysfunctions, or any kind of stress. So we cannot completely rely on troponin in COVID-19.
Okay. Dr. Raghavan, one more question for you from Dr. S.P. Singh. Role of low-dose colchicine with thrombolysis in acute MI with COVID.
Yep. That has got an excellent role of late. Lot of trials are coming on and which have shown that it has got a very good anti-inflammatory properties. So colchicine can be used in patients who have been thrombolized or who have undergone an angioplasty post myocardial infarction. It has been shown to be of good benefit.
There are multiple good questions by many doctors, but because of thing, but I'll keep asking as long as Dr. Parikh allows me to ask. Dr. Pancholi, is a question by Dr. Raghavendra Stapak. Is there any difference of outcome in uncontrolled hypertension and controlled blood hypertension in COVID-19? Difference in outcome in uncontrolled and controlled hypertension?
Yes, as I said earlier, it is unclear whether the uncontrolled hypertension having a low risk. But it is very clear that uncontrolled hypertension, and particularly when it is associated with target organ damage, then the outcome is poor in these patients. And as I said earlier, in those who the patient who died, the mortality they found hypertension around 50% of the patients.
Yeah, Dr. Pancholi, Dr. Ashok Sharaf wants to know: can we start ARB to newly detected hypertensive in a corona positive patient? Dr. Ashok Saraf wants to say, can we start ARB to newly detected hypertensive in a corona positive patients?
Yes, why not? Because as I already said, there's a dual effect of the ARBs in these particular patients, the COVID patients, and even in non-COVID patient also there is a recommendation by the NICE guideline and by the British Hypertension guideline. And COVID patients, there is an additional advantage, as I said earlier, because of this upregulation of the ACE2 and more conversion to A1, this angiotensin 1-7 and having all the beneficial effects.
Okay, one more question to Dr. Pancholi. Dr. Sachin Kule wants to say, what about beta blockers in COVID-19?
It is not associated with COVID or non-COVID. The beta blockers, when there is associated coronary artery disease, hypertension, then of course it is the first line of choice, whether it is COVID or it is non-COVID.
There is another question by Dr. N. Sarkar, which I will answer. He writes, lopinavir, ritonavir, along with hydroxychloroquine, guidelines to use in preventive or treatment. Dr. Sarkar, I would like to tell you that these are the few HIV drugs. The HIV has the same genetic configuration partly like COVID-19 virus. So initially hydroxychloroquine was used with lopinavir and ritonavir, and with utmost monitoring of the parameters with QT interval. But lately, there has been not great studies in favor of ritonavir and lopinavir. So hydroxychloroquine stands to be continued. Ritonavir and lopinavir, because not very strong data in favor, they are the few of the non-specific antiviral drug because of genetic configuration of HIV virus being similar with the COVID-19 virus is being tried, but still more longer trials have to come. Although in vitro, these true drugs were found to be effective against COVID-19 virus. We have another question by Dr. Vijay Bhaskar for Dr. Mukul. In the worldwide, which are the countries where SCQS has been useful and to what extent in fact, this question I'll raise to Dr. Pari. Dr. A. Vijaya Bhaskar says, Dr. Pari,
Yeah.
in the worldwide, which are the countries where SCQS has been useful and to what extent in the COVID-19 patient? Countries he wants to know. Yeah, in how many countries? Yeah.
There was actually a study where, in some countries where hydroxychloroquine is being used as part of treatment strategy, like our countries there, India, then South Korea, then France, US also to an extent, where hydroxychloroquine has been used, and countries where hydroxychloroquine is not being used. China also includes among countries where it is used. And as compared to countries where, antimalarials are not part of the treatment protocol. And that article just came last week, and they said that, mortality rate is better in countries where it is used as a strategy.
Yeah.
So just
now there are 2 to 3 questions again. Very difficult questions for you, Dr. Pari.
Yeah.
Dr. M. Surendra Nehru writes SCQA Hawks, and there another doctor this is one, and the another Dr. Syed Yusuf Ali writes, sir, any drug interaction with ACE inhibitor in hypertension COVID-19? What are the precautions could be taken before starting SCQ in COVID-19?
Okay, so I think the question is whether it is a hoax or not is you should not say it is a hoax, because still you have a conclusive evidence. As US FDA itself, the US task, NIH task force of US, it came out after a negative study. They said, particularly it started with a veteran affairs study where it was not a clinical trial, but it was a retrospective observational study at veteran affairs centers, where they showed that, in some patient it is not working. But that was a retrospective study where you cannot be taken as a conclusive evidence. For conclusive evidence, you require randomized controlled trials, and that too also not small, but relatively of good size. So that we still don't have, as I said before only. So that for no drug, there is a randomized controlled trial available. So in the absence of any other drug, the US FDA, the ICMR, the Ministry of Health, they are recommending this drug, and Dr. Sudhir himself has used in large scale himself. As example of more than 300 patients, he has used it. So I don't think it is a hoax.
I have a feeling it will be a too premature comment to talk like this, because we have been using hydroxychloroquine for ages. You need to understand, it is not a drug like oseltamivir for H1N1. It is not an ultimate drug. It is a drug to be used in initial stage to have some of its beneficial effect. It is not a drug which can be totally dependent on is antiplatelet drug. Totally, it is not a strong antiviral drug. It is not a strong anti-inflammatory drug. It is a cumulative small effect which could be useful in early stages. And how cytokine levels falls after using hydroxychloroquine, it is studied to be done through. It is a milder drug to be used initially with some added advantage, with more benefits than any side effect. There's a very interesting question for you, Dr. Raghavan. Dr. M. Surendra says ECO is useless. What do you comment about it in COVID-19? Dr. M. Surendra says ECO is useless. Dr. Raghavan?
Well, if you go by your basic protocols, when you rule out the various causes of dyspnea, so one of the investigation you have to do is echocardiography. And when we are clearly telling that there has been documented evidences of underlying acute myocardial injury, maybe in the form of myocardial infarction or myocarditis, apart from echocardiography, is the first test where we will find that the patient is having a low ejection fraction or any underlying regional wall motion abnormality. So it is very important, and it does play a significant role in ruling out one of the causes for dyspnea in these patients. before we move.
Correct. Dr. Mukul, there is a question for you from Sanjay Dhar. What antihypertensive medicine we should recommend in COVID-19 patient diagnosed hypertensive first time?
The indications of antihypertensive will remain same whether it is COVID or non-COVID, depending on whether patient is having, what is the age of the patient, whether it is only systolic hypertension, whether, so all those factors have to be taken in account, and accordingly we have to, and what is the stage of that hypertension. Like only in systolic hypertension, old age, we will start CCBs, or depending on all these factors, they will remain same whether COVID or non-COVID.
Dr. Parikh, there's a question for you.
Yeah.
By Leela Choksi, give us a list of drugs which makes giving SCQS dangerous except azithromycin and digoxin. What are the other drug effects?
Yeah, there are actually precautions in terms of mainly QT prolongation is there. So that with azole antifungals are the one, class 1 and class 3 antiarrhythmics are there. Antipsychotics and antidepressants medications, they come in that list. So, and plus drugs which are arrhythmogenic like moxifloxacin and the drug which we were discussing, amiodarone. So these are the drugs which we would need to avoid, which can prolong QT interval. And if you have to use, then obviously you have to use under ECG monitoring, and do the QT, and then you can use them under close QT monitoring, QTC monitoring, you can do it. So these are, yeah.
Another question to you, Dr. Parikh, by Vishnu Mulchandani, doses of SCQS in prophylaxis.
Doses of HCQ is in prophylaxis is governed by an in vitro study, which ICMR has also referred to, and Dr. Pancholi also pointed out earlier. 400 milligram 12 hourly on the first day, and followed by 400 milligram weekly. For context, it is 3 weeks, and for healthcare personnel, it is 7 weeks. So that is what is the recommendation of ICMR, and we have to go by what ICMR is saying. I think since there are no clinical data on prophylaxis, but there is a strong rationale for giving the drug as a prophylaxis in the absence of any other thing. So this is, I think we should follow the ICMR guidelines.
Dr. Dr. Raghavan or Mukul, you could take this question. There is a one, Dr. Jivokoy. How many patients of COVID, any study shown number of angiograms and angioplasty done in those? Any study you are aware of in which
there is no study, but what we have found out is there have been a lot of things which we have been hearing from our colleagues, that patients are presented like acute myocardial infarction when the angiography done was normal and they were found to be COVID-19 positive. So as such, there are no documented studies on these. That is why WHO has already now, this ACC has made it very clear, better to thrombolize rather than directly going for a primary angioplasty in these group of patients. That is one of the main reasons why this is covered.
For Dr. Parikh, there is a question on SCQS. Should we adjust the dose of SCQS in cardiac patients?
I think cardiac patients, as such, there is no dose adjustment required unless the renal function is compromised. So most important factor to consider while giving hydroxychloroquine is the renal function normality. You have to go by the EGFR estimated glomerular filtration rate. Right? If it is less than 60, then you need to reduce the dose. That's but cardiac patient as such, there is no dose reduction required unless. But you have to rule out the underlying conduction abnormality, and then I think you can use it. QTC and under conduction abnormality has to be ruled out, and then you have to see the other drug interactions, and then it can be used in cardiac patients. In fact, with the experience of rheumatoid arthritis, University of Pittsburgh, they have shown that in patients of rheumatoid arthritis, there is a reduction in CV mortality to the extent of 72% over a 12-year period. So the drug does produce a cardio, beneficial effect in rheumatoid and lupus patients when you use the drug long term.
Yeah, there is another question by Dr. Vimal Mishra. Is there any role of monoclonal antibodies in COVID, Dr. Pancholi? Is there any role of monoclonal antibodies in COVID?
Sorry, I don't know.
Truly speaking, there is no role of monoclonal antibodies. Specific COVID antibodies has been tried. It is yet experiment stage. So COVID IgG, IgM containing plasma has been tried. There is a
I think
another.
I think what the viewer may be asking, I think, is about the tocilizumab, which are the
Yes.
the interleukin antagonists. I think those drugs he may be asking. So there is, I think, occasional case reports of that being used in when there is an intense cytokine storm. People have tried that.
There's a Dr. Vimal Mishra who is asking, can we use quinolines if indicated in family practice with SCQS prophylaxis? Dr. Pari?
I think we should avoid quinolines and HCQ together, because both will prolong the QT interval again, as moxifloxacin example we have given. And there may be additive arrhythmia, and so better to avoid quinolones and hydroxychloroquine together.
Now, there are two more questions for Dr. Pari. One is Dr. Krishna Bhatt. As of now, any rule for ivermectin, especially as there is no specific drug? Are we going to give SCQ or ivermectin to cluster places like Dharvi, where the rest of the measures are tough? Mass treatment in next generation. So he's asking Dr. Krishna Bhatt as a combination of ivermectin.
I think ivermectin has shown a in vitro profile of activity against the COVID virus, but there are no clinical data so far. So in the absence of any clinical data, again, it remains a conjecture unless somebody comes out with some clinical data on usefulness of in vitro translating in vivo.
There is a Dr. Raj Mathuri wants to ask you, Dr. Pari, role of SCQ/chloroquine as a prophylaxis for family physician.
I think if the family physicians is very clear, if they are seeing suspected COVID-19 patients, if they are seeing, I think the same ICMR guideline can be applied. But if they are not seeing COVID-19 patients, then there is no need for them to take. But if they feel that in their area, there is a good chance of COVID-19 suspected patients coming to them, then they can use it.
Yeah, so that's a very interesting. And there's a very interesting question. Dr. Pancholi, you advise Dr. Arvind Kumar, he is a diabetic doctor. Should he see OPD patient or not? So what is your advice? I think a very interesting, a diabetic doctor asking, should he go to OPD or not? All of you panelists can advise. Dr. Pancholi, Mukul, and
see, in our city, the administration strictly says not to open your OPDs, your routine OPD. Only you can go to hospitals, but not your clinics. That's the instruction from the administration.
But telemedication, you can do.
Telemedication, yes, we are doing almost daily telemedication. And for diabetic patients and hypertension patients, telemedicine may work very well. You need not to see the patient.
Fine. So I think there are 106 questions. There are too many questions all around. It's been a wonderful interacting with our fellow colleagues, a very enlightening questions. I think I would like all of you to give a final message before I conclude. So we start with a message from Dr. Pancholi, and then we follow others. Dr. Pancholi.
Yes, my message in the COVID-19, this pandemic, the comorbidities are very common. Hypertension is the commonest comorbidity. So all the patients who are hypertensive. So my recommendation to patients, my advice to the doctors, my advice to the hypertension specialists, that try to control control the blood pressure of their patients very nicely. And if they are on RAS blockers, should not discontinue the RAS blockers or should not withdraw the RAS blockers in them.
Very nice. Dr. Mukul?
I would say stay home, stay safe till we get a definite treatment for this disease, and continue your medication as before.
Dr. Raghavan?
I would like to say, especially for cardiac group of patients, that it is not that if they are a cardiac patient, they will be having this disease. It is just that patients with special conditions, it is going to be affecting more, especially who are diabetic or who are on any immunosuppression therapy. I would recommend they should maintain proper distance, stay safe, and they should stay at home. I would recommend that.
I think it has been a great interaction, especially talking about the hypertension and cardiac problem in relation to COVID-19. Two important consensus were that we should continue ACE inhibitors or ARBs as it is. We should not worry about it changing or anything. But the bottom line is that we should control the blood pressure properly. we should continue cardiac medications, and patients should stay comfortable at rest. Second important thing is that if there is an acute cardiac episode or coronary syndrome, the thrombolysis is a need of hour. And if the patient not responding to thrombolysis, then in a COVID protective and protocol wise, the intervention could be thought of. Thirdly, important thing is that diabetic management has to be perfect, because diabetic patients are very high risk, low resistance patient. So one need to monitor the sugar in a given circumstances of less activity, changing food habit, lack of exercise and walking. Probably people will have to adjust the doses, which they should try to do with the teleconsultation with their consultant. If someone is a type 1 diabetic, who need to be little more careful because of proneness for ketoacidosis, which also predisposes to the complication. Lastly, there was one question I did not speak because I thought I'll reply once I summarize. One of the doctors, I would take his name, asked, what about the sanitization of uh, the sanitization of the gloves which they wear? This is Dr. Neela Choksi, that if you are wearing the gloves, then definitely you are protecting your hands. And the best way is 20 seconds of washing hands with a detergent. And if you use a sanitizer also, you need to use 3 to 5 ml of sanitizer for 20 seconds of killing all the surfaces. But more important is that make sure you don't touch your face, eyes, nose, etc. with the hands. One of the very important observation I would like to share with you with the COVID infection, that it is the nasopharynx and the respiratory tract, which is a source in which the virus finds its way into the body. So just a common precaution all of you can take, that taking the warm waters, preventing the touching of hand to the nose and mouth, keeping yourself masked all the time. And if you are able to take steam, I think that should also help you. So this is very important. Secondly, the 80% are asymptomatic, to reassure people. But if anyone with a 60 plus cardiac, hypertensive and diabetic, they need to be seen with a very high suspicion. We need to be very careful about cytokine storm, which Dr. Pancholi has very well spoken. We need to be very careful about blood pressure control, which Dr. Mukul and Raghavan has very well spoken. And probably you should be in touch with consultants to teleconsultations. And I must profusely thank Dr. Pari, who has been absolutely very illustrative on HCQ. And I must share with my colleagues that it is not the final, it is not the ultimate drug that you give so much of credit and so much of discredit to this drug. It is a drug to begin with. It is a drug which has certain advantages with practically negligible side effect. So it is not a drug to be outrightly rejected, but it can be thought of, it can be considered, and I think we should be open to longer and bigger trials. Now I would hand over to Dr. Pari for his final closing down comments.
Thank you, sir. But before I would like to you to, since you have been part of the hydroxychloroquine journey as a diabetes, as an anti-diabetic drug, what is your? Will you give some? You speak on what is the role of hydroxychloroquine in type 2 diabetes patients who are COVID positive? In them, the inflammation. What do you say?
Truly speaking, in COVID patients, we have been finding a lot of dysglycemia. In many of the patients who were on sulfonylureas, we had to reduce or stop the drugs. Hydroxychloroquine is also very strong anti-inflammatory and a good anti-diabetic drug. So we won't mind continuing this, but definitely the bottom line in diabetic patient is that we need to ensure euglycemia. We need to prevent hyperglycemia and hypoglycemia. But it is a drug, if the patient is already on, we would like to continue. And as an anti-inflammatory, I've been a part of this drug in a type 2 diabetic control trial. Before a patient, at the end of the, what happens? What is a secondary failure? Secondary failure is a situation when there is a total beta cell loss and there is a insulin resistance. So a patient who has a total beta cell mass loss, there is a stage where you have 2 to 3 drugs you give and patient doesn't have good control and you think of insulin and GLP-1 analogs. I think we have been using this drug in a good number of a prolonged, all type 2 diabetic patients become insulinopenic after a certain time. And we have been using various drugs. Introduction of an anti-inflammatory drug which leads to the beta cell apoptosis and which contributes to the beta cell deficiency. I think there has been a lot of good contributory and protective effect is there. So as an anti-inflammatory, it is a good drug to be used. In fact, you can feel confident once you start using this drug. So let individual have his own experience, but it's a good drug to be added as an anti-inflammatory drug to prevent the beta cell apoptosis, to maintain the insulin and to delay the total insulinopenic stage. And because of this multifarious good effects, I think is a drug to be thought of. But again, I repeat, don't think that it is an ultimate drug. It is a drug with certain advantages which can be thought of till the specific drugs are not available. So it is a drug to be considered, drug to be thought. As an initial uses drug, is a mild drug with some added advantage, not an ultimate drug as a true only drug to take care of the impact. And so as a diabetic users of this drug, anti-inflammatory uses in type 2 diabetes is definitely significant.
So thank you very much, sir. And it's my my utmost gratitude to all the panelists, Dr. Pancholia, Dr.
My apologies, because there were huge number of questions, which you may directly address to Dr. Parikh, please. He's a brilliant person to answer, because there were so many questions. I could read out only few. My apologies for that.
Yeah. So my sincere gratitude and thanks to all the today's faculty, and in particular Dr. Sudhir Bhandari, who moderated so well. And since it was great to have the first-hand experience to listen to Dr. Sudhir Bhandari. Thank you all, and I thank all the participant doctors from across the country who have been attending this. I hope it is as beneficial to you as it has been beneficial to me, and to increase our knowledge. It's a rapidly evolving era of Covid-19, and the situation is rapidly changing. New and new trials are repeatedly coming, and things are changing. So we should be prepared to accept whatever the good evidence comes. We should be ready to adopt that, and I'm ready to adopt any new evidence which comes. Thank you very much, sir. Thanks a lot.
Thank you. Thank you. Thank you very much to all of you. Thank you very much.
Thank you. Thank you very much.
Thank you. Thank you. Thank you.